And welcome back to the Wellness Paradox podcast. I'm so grateful that you've joined us on this journey towards greater human flourishing. As always, I'm your host, Michael Stack, an exercise physiologist by training and a health entrepreneur and a health educator by trade. And I'm fascinated by a phenomena that I call the wellness paradox. Now, if you haven't listened to episode 13, and maybe you've listened to some of the previous episodes, you heard me previously define the wellness paradox as the gap between what we know as a health sciences community and what we actually implement in the real world to make a real difference with real people. In episode 13, we redefined what the wellness paradox meant after some deep reflection on my part and the first 12 episodes of the podcast. And now we are focusing on the paradox of the fact that wellness and fitness professionals simply aren't part of our healthcare delivery system. They don't communicate with medical professionals, yet they have all the amazing skills and abilities to address many of the chronic lifestyle diseases that plague our society. And we've now transitioned the podcast to addressing this wellness paradox, the true deep wellness paradox that I felt for the 22 years of my career. And that's what we're excited to get into today with Mark Stoutenberg from the American College of Sport Medicine's Exercise as Medicine Initiative. Now, if you're listening to this podcast and you're in the fitness or the wellness industry, or maybe you're in medicine, I would bet any money that when you hear exercise as medicine, you get up and you say amen and you throw your hands towards the sky, because I firmly believe that all of us that are involved in the health and wellness ecosystem truly feel that exercise is medicine. Yet at the same time, it doesn't seem to be prescribed anywhere near as liberally as a lot of the medications that are used to treat chronic lifestyle diseases. Although we know exercise and physical activity, both being slightly different things, mind you, physical activity being just any body movement, whereas exercise being something that's a little bit more intense and a little bit more finite. Exercise and physical activity can both help ameliorate a myriad of different chronic non-infectious diseases, diabetes, cardiovascular disease, the list goes on and on. I'm sure I don't have to tell that to this audience that's listening. And the Exercise as Medicine Initiative is something that, as I'll state in the podcast, I think a decent number of people in our industry know about the concept of exercise as medicine as a formal initiative from the ASCM, but I feel like outside of the walls of our industry, it doesn't necessarily get a lot of press, or at the very least, it's not utilized. And we're going to dive into some of the challenges with exercise is medicine as a formal healthcare initiative, primarily those issues being associated with reimbursement for care that would be related to exercise and physical activity, and then looking at the outcome metrics that are associated with physical activity and exercise interventions and how that helps to address the chronic burden of disease, as well as the cost factors that are associated with those diseases. This is a more complex and nuanced discussion than what I think most people realize when they make the statement exercise is medicine. The statement is almost so self-evident that at some points in times, I feel like we think that we don't need to make it, but it is important to make the statement. And then even more importantly, it's necessary to back it up with data and infrastructure and systems to ensure we can effectuate exercise as medicine in our healthcare delivery system. I can't think of a better podcast to follow up the podcast from last week where we talked about why we were transitioning and what we were transitioning to than this podcast on the Exercise as Medicine Initiative. As always, you can find additional information about this episode on the show notes page by going to wellnessparadoxpod.com/episode 14. I hope you enjoyed this conversation with Dr. Mark Stoutenberg. Joined by Mark Stoutenberg here on the Wellness Paradox podcast. Mark, thank you so much for joining us.
Yeah, my pleasure. I'm excited. Thank you.
Awesome. So we're here to talk a little bit about the ASCM's Exercise as Medicine Initiative. And before we started, we were talking about how this is a great initiative that unfortunately I don't think enough people actually know about. But before we launch into EIM and some of the exciting things you're doing as a part of the Research Learning Collaborative, why don't you tell our listeners just a little bit about your background and how you got involved with the ACSM?
Did my PhD in exercise physiology at the University of Miami. Moved on to a faculty position in the Department of Public Health, really looking at how we could promote physical activity at a population level. And, being a loyal member of the American College of Sports Medicine, I'd attend the annual meetings. And I think it must have been like 2010, and it was in Denver. And they had a big gala for the, EIM. And I walked around the room and I saw all these posters of programs in Colombia and, Asia, and people getting excited about this. And I was like, this is it. This is, it's physical activity promotion, but in a public health setting, through the healthcare sector. And I was just like, I want to get involved.
Talk a little bit about exercise as medicine, because I don't think, like I said, enough people outside of maybe the American College of Sport Medicine community and a very small subset of the medical community understand it. What's some of the goals of the initiative and what's it doing?
Well, and I think you hit right on the head there. Is, at first you were saying it's not publicized. It's really well publicized to people in our field.
Yeah.
It's extremely well branded. I mean, every person that goes through an exercise science program has probably heard of it. Maybe they don't quite fully understand it. They've heard of it. It's out there. ACSM likes to say it's one of their most valuable assets because of the branding. The problem is, and I think what we do sometimes in the world of exercise or physical activity is we know how important and how beneficial it is. But what we don't realize is that people outside our field have a million issues, so like EIM focuses on the healthcare sector. Well, physicians and nurses, they're worried about drug use, mental health, social determinants of health. There are so many things they're being asked to do that really the world of exercise and physical activity is way, way down on their list. So you hit it right on the head. I mean, we know about it. Our members know about it. But what our challenge is how do we get it to become more mainstream to the healthcare world? And that's a challenge we're facing and trying to overcome.
Yeah, and you said it. It's the clinical care setting is so fast paced. It is so busy, and as important as we know exercise and activity is, the urgent always trumps the important, and all of those other things you mentioned are the urgent matters.
Yeah.
So what is ACSM and EIM doing to try to make this more of a priority in the clinical world? How are they looking to try to publicize it more?
Well, we've tried different approaches. I would say that, maybe 5 years ago, our focus was working with health systems, and at that point, with Obamacare, there was an emphasis on prevention, public health, population health initiatives. So we're actually getting calls and setting up appointments with, executives of health systems from around the country. I'd say 30, 40, 50 meetings. And they were interested because we were presenting them a primary and secondary prevention strategy that they could implement in their health systems. And so there was a lot of excitement, and not too much of it went to the next step. Mm-hmm. It didn't trickle down. It didn't get implemented. I think a lot of that has to eventually do with the reimbursement policies for exercise and exercise program. Kind of says, if we do this and we do that and we do this, well, who's going to pay for it? Mm-hmm. And that's something I think as a field, not just EIM, but as a field, we struggle with. Who's going to pay for it? It's not like these other fields where we have reimbursable policies. And so that happens. So we've kind of shifted a little bit, realizing that there's a gap there. And we said, well, maybe we can work with the professional societies. So the American Academy of Nurse Practitioners, the American Association of Family Practitioners. There's a lot of partnerships we have going on with those folks. Trying to get more knowledge to the members, develop those champions. And it might take a while. So our approach is now, well, can we convert enough champions that go back to their health system and then kind of grow this organically through that? So I would say that's probably our biggest approach. We try and get out and present at professional conferences to get in front of audiences. I remember a few years ago, we did a presentation with the American Physical Therapy Association. It was a keynote presentation. We had 1,200 people in the room. So that's 1,200 physical therapists all hearing about exercise medicine, all thinking about how this partnership would work, how they could implement it, aspects of it into their clinic. It's just something we need to keep pushing, and we need more people engaged with. And we've come a long way, but there's a long way to go.
Yeah, I think it's interesting. It's the top down approach didn't seem to bear the fruit that you wanted. So I feel like any good movement starts with a great grassroots effort, and it seems like that's your focus.
And the answer is probably we need a little bit of everything. We need to hit it from all different angles and all different sides, and get the grassroots champions fighting for it, but also be talking to the administrators, and then figuring out what we have to do on a policy end to get that reimbursement through, to try and, and so it's just, there's a lot to do. The health system is a very set, rigid, immovable force. And, but if we can ever do this, it's going to have a significant impact on health.
Yeah, absolutely. And you said something earlier, which is the linchpin of this whole thing on some level, is the reimbursement piece. And obviously, reimbursement comes from good evidence, and this being vetted in a research setting. And the ACSM EIM initiative has developed this research learning collaborative that is actually starting to look at this from a data perspective. So talk a little bit about the research learning collaborative, what its goals are, and what are some of the early findings.
Well, I think it really was, this idea was born out of a meeting we had with multiple ACSM leaders. And we talked about the different areas of EIM and the evidence base. And we keep coming back to the evidence isn't overwhelmingly strong, that not about physical activity. I mean, we know physical activity and exercise works, but the actual implementation of physical activity into a health setting. Does it really improve patient health outcomes? Does it really save that health system money? I mean, we're all 99% sure it does. I think Intermountain Health, which is a very large system in Utah, they're showing that prevention is really saving them a lot of money. But we need more data. And we're like, well, who's doing this? And the answer was nobody. Well, who's looking at this? Nobody. Where's the evidence? And what we do get, not just in the US, but worldwide. A recent example is our EIM team in Greece has a meeting with the Minister of Health. They're looking at implementing into their national health system. So again, because it's nationalized health, they don't have this reimbursable private insurance. So when the government says, we want to implement it, that's like amazing. And they said, can you show us the data? And we're like, and so we can show data, little snippets, but not the whole comprehensive program. And so we're like, wow, we got to do something about this. And how can we really increase research output? Something we call bidirectional learning. It's got to be pragmatic. It's got to work for the health system. So it can't be just what a bunch of scientists come along. But at the same time, it's got to be something where it's rigorous enough that our findings are something that will be accepted by health systems and the ministries of health and different things like that. So it's really a bi-directional process. And it just grew out of that and said, well, we just don't have enough people doing this. It's not even that there's not enough evidence. We just don't even have enough people even doing this. So how do we get more people doing this? I said, well, maybe there'll be people who are experienced researchers that switch their field. But really, I think what we have to do is start developing people from the ground up and giving them this exposure and showing them what's out there and helping them guide them. So, it really grew from that idea. And we said, let's try. We're at the end of our first year. We've put on many successful symposiums. We have I think we're right near around 300 people that are kind of signed up to be part of this listserv and part of it. And we usually get, upwards of 100 people on our different panels and sessions. And we're just constantly thinking, how can we make this more impactful to really help train other people to do this research in the future?
Yeah, I've been on several of those webinars, and they're they're very informative, and it does really lay a framework for doing this kind of research. Give us a little bit of an idea of what you see this research focusing on. Like thus far, I know there's been some research that you guys have been able to do and talk about. What's been the focus and maybe some of the preliminary findings?
History of EIM is when it started in 2007, and maybe for the first 5-6 years, it was really about promotion and awareness of physical activity. So we kind of called that our philosophical stage, where it was like, exercise is good for you. And so we, if you go back to the conferences back then, it was like, this is the benefits of exercise with Alzheimer's patients, and this is the benefits of exercise in patients with diabetes, and that was all good. And I think the evidence in many of these areas is overwhelming. But what we really wanted to do was shift it to the actual implementation or application. How do we put physical activity into the healthcare sector? And so now we're looking at not almost that assumption. We know exercise is good and it works, and if people do it, most people will experience health benefits. So we kind of start from that assumption. So now we say, okay, so how do we maneuver this? How do we get an assessment into the health system that's pragmatic, that a very busy nurse will do in 30-40 seconds? Okay, boom, that's the physical activity vital sign. And it's something that actually has a ton of evidence. And so we got the first piece that's going. And it's like, okay, so what happens in a clinic flow next? What should happen next? And so we talk to physicians. We have a clinical practice committee. They guide us and they say, well, this is what's realistic, some brief counseling, maybe printing out some order sets, but it has to be automated. It has to be quick. Okay, great. So that's kind of our next step. Then what do we have to do? Well, we really have to connect them with resources, supportive resources, programs, professionals, and places where they can be physically active. Good, we have that. Well, how do we make this work? How do we see if it actually gets implemented and the steps are followed? So now we're almost shifting into this world of implementation science, where we're not looking at, is it effective? Because we know physical activity is effective, but how do we implement this into a health system and get people to do it the way we hope they'll do it, right? And so that's kind of the crux of what we're doing. Then, at the backside, we get the patients connected to the programs, and we can always measure, are these programs effective? Are they doing what we assume that they will do, which is improve patient outcomes, health outcomes? Once you get the improved patient health outcomes, now you can say, okay, so a person with diabetes went to this program, they improved their health by X%, and that improvement led to this cost savings for the health system or the health insurance companies. So, the first part is implementation science. What do we need to do to get this implemented into a health system and connect patients? Then we look at it kind of from an effectiveness standpoint. Does the physical activity programs really improve their health? And then we have to bring in the health economics folks to say, okay, well, when we see that improvement, how much money is it saving the system? Because at the end of the day, that's what they care about. So we have to do all these steps to get that health analysis, economic analysis. We get those numbers, and those will be the numbers down the road that really will drive the expansion of this, saying, wow, if we do this, we're going to save this much money and improve patient health.
Yeah, it's really a whole ecosystem approach. You really have to address all sides of it. You mentioned the physical activity vital sign, and you and I both know what that is, but I don't think enough people, to the point we were making earlier, know what that is. Can you explain a little bit more about that and how that gets integrated into health systems?
Yeah, it's an interesting debate, because you get this spectrum of people who are really enthusiastic about physical activity, and we have to have really like the highest gold standard objective measurements, right? But then you go into a health system and they say, listen, if we're going to make time for this, we'll give you 30 seconds. So then you got the one side, you have people arguing we need like really gold standard measurements. And then you have the pragmatic people saying, yeah, but gold standard measurements don't do us any good if they're not being utilized.
Yep.
And, Bob Salas, the founder of EIM, and his work in Kaiser Permanente, he was really the first, and he got it into their health system. And it's a simple 2-question, how many days a week are you physically active, and how many minutes each time? You multiply the two together, and we can see, roughly if they're meeting the national guidelines of 150 minutes of moderate intensity aerobic activity a week. And is it perfect? No. And there's a lot of people out there is like, this is not accurate, and it's self-report, and but then a lot of people have come along. It was adopted by Intermountain Health, and that team did a really wonderful job, led by Liz Joy and Trevor Ball, of diving into it and saying, well, how accurate is this information? And they started doing studies where they would track the self-reported physical activity vital sign versus accelerometry. The numbers weren't horribly far off. And then we looked at reliability. We looked at the associations with people who are overweight or obese. We looked at, glucose levels, and everything tracked pretty well, to the point where we are at a place where we feel confident that this gives us at least a reasonably accurate assessment that asking these 2 questions in 30 seconds, which is pragmatic and accepted by health systems, will give us a fairly good idea of people's physical activity levels. And then we can say, okay, well, this person now is reporting 150, 200 minutes a week. So the strategy with them now becomes more of a maintenance strategy, rather than a person that's 0 to 50 minutes a week. Now we got to look and kind of engage them in a very different type of way. So we've had, surprisingly, we've had a lot of success. It's been picked up. I know the Mayo Clinic picked that up at one point. Emory Health in Atlanta has picked it up. I mean, it's more and more. Michigan, different clinics in Michigan, University of Michigan Health System picked it up. The challenge we're still facing with it, though, is that it's not in most cases, it's not like what they call a hard stop or a required part. So physicians don't, and nurses and the healthcare team don't have to ask the questions. They have to do blood pressure, they have to do body weight, but they don't have to do the physical activity vital signs. So when it's not implemented correctly, we can see utilization rates as low as 15 to 20%. But in Intermountain Health, where they've really figured out how to incentivize properly, we see 70 to 80%. So it's not just, so that you add another wrinkle. It's not just, oh, we've got it into the health system. You just put it into a health system, no one's going to use it. So you have to train people, you have to educate them, and then you have to incentivize them to do it.
Yeah, and that's striking to me, because like you said earlier, we basically have all the evidence that tells us physical activity is critically important for health and longevity. Everyone just kind of accepts that at face value. We need to tie in the health, the reimbursement component. We need to tie in the cost effectiveness component, certainly. But at its most basic level, if I'm sitting here just listening to this as just a physician or a nurse or someone in a health system, I'm going, well, this is great. How come this isn't in every health system? How come this isn't implemented 90% of the time? What do you think the barrier is to getting it in and then to actually utilizing it once it's in there? And I realize that's a challenging question to answer, but I'm curious from your perspective why that lag exists.
Well, I think health systems can be rigid. They're very large, and as such, there's a lot of different things going on. And so anything to large organizations can, be really tough unless you get the top guy, the top person saying, we're doing this and I'm pushing it. Number two, I think there's a lot of competing priorities, right? They're trying to get a pain vital sign. That's the big thing, is pain as a 6th vital sign. Nutrition people want to get their questions in. So there's a lot of different things that are coming out. One of the encouraging things is Epic, one of the main electronic health records systems out there, is, I believe they're adding like a new tab on social determinants of health. That's been such a big thing in the health systems, is not just looking at a patient and, oh, you're hypertensive, but looking at the neighborhood, the zip code they're from. I think health systems are starting to move in that direction. And so in this social determinants of health tab, we've had conversations with Epic can physical activity be included in there? And so it looks like it's going to be included, the physical activity vital sign, as a part of this tab, but again, it's optional. So, a healthcare team doesn't have to use it. They have to, willingly click over there. So again, the people who really believe in physical activity, they're more likely to do it. But the other busy healthcare teams, they might focus on just the bare, the most important things or the urgent things, as you said. So I think that's a big thing. Knowing that it's there, how do we then prioritize people using it? And then on top of that, getting the data out is another beast altogether, because you're trying to data mine from EHR where there's billions of records. And I've never done it, but I've the people who do it, I've heard it's not as easy as you think it is. So there's a lot of hurdles. But people do this work in other fields, right? They do, there's a lot of people that do this exact work, but it might be in colon cancer screening. It might be and maybe because there's more in reimbursements policies, or for whatever reason, there just seems to be more support. There's more grant funding to encourage people to do research in these areas. So those are things we're trying to break down. And again, I don't think there's any one way to do it. I think there's just a million different things. We need more people involved that really have a passion for this.
Yeah, and on that note, you mentioned this earlier. We're talking about one side of the coin here, which is the clinical piece, recording the physical activity vital sign, and then maybe some brief intervention on the part of the physician or nurse practitioner. Like you said, their time is limited. They're not going to do an exercise prescription for the patient on the spot. So we need to connect these people with community resources. To that end, what role do you see the larger fitness industry playing in being a good, viable community resource for referrals from physicians and just being able to facilitate the care on the end user side of this?
Well, and yeah, we've spent a lot of time speaking about the health system side of things. And a health system can go through and do, there's an adopter and they just want to do, what we've talked about. And we've seen a couple of these, but it doesn't work if we don't have the physical activity side, the resources set up and everything. And that's its own challenge, right? Because, who's paying them, right? Who's when a patient comes over and they're doing their programs, I mean, yeah, maybe the patients who can afford it, but that's a very, very small percent of our population. Most people aren't willing to put out the $250 for a 12-week program. They should, we spend that much on food, and leisure and different things. I mean, but as a society, we tend not to do that. And then you think about, going back to those social determinants of health, there's a lot of people that can't afford that. So how do we work around these barriers? And those are things that are a challenge. Now, the other thing with developing that community network that you mentioned is it really varies, because health systems you might find a health system that just says, we're willing to engage with the community. We'll take anything. We'll take walking programs in the park. We'll take programs at YMCAs. We'll do this. But other health systems might be a little bit more risk averse, and they see now, okay, we're referring our patients to you, but if the patients get hurt there, they could come back and sue us because we did the referral. And so it's really kind of a understanding and working with the local health systems and the people who are doing the referring, say, what are your criteria? And so within that, we've developed the EIM credential. That the vision for this is that we're training exercise professionals to understand how to work as an extended part of the healthcare team, to create a brand within EIM that, one day a health professional will say, I can trust these people. Because I would have to imagine that, a physician or a nurse or any healthcare team member that doesn't really know the physical activity landscape can look out there and say, there's 30 different personal training certifications. Which person out there should I trust?
Yep.
And even at that, I mean, my day job at Temple, we train students. We train hundreds of students, like many programs in exercise science. They can go out and they get a certification, but a lot of times they don't have in-depth training of how to work with a pregnant woman. So you get an OB-GYN physician saying, really need to be physically active. I would like to refer you. But then they get stuck and they say, well, who in the community truly has the expertise, not just an exercise professional, but to understand how to work with a woman in month 6 of a pregnancy? And most students coming out of an exercise science program don't have that expertise. So we have to fill that void. But then you get to the chicken and the egg issue as you fill that void, there's no guarantee that patients are going to be referred.
Sure.
So, you train people on, if you build it, will they come? Type of premise, if that makes any sense.
Yeah. And so the ACSM does have their EIM credential for fitness professionals. And as you said, it kind of sits into this large just conglomeration of all the different certifications that are out there. Touch on that really briefly, what that credential looks like, what it covers, and why it makes a professional more qualified to almost be an extension of the healthcare continuum.
Yeah, well, the first thing I'd like to add is we're revamping it to update it to offer a better training. I think it's going to be still 6 to 8 months, probably at the beginning of 2022. We'll have the new one out. Our team is doing a fantastic job of doing a really interactive training. The current one is a bunch of really nice videos, but you just sit there and you listen to videos. The new one's going to be interactive. The really great thing about ACSM is just we have so many incredibly knowledgeable, smart people. And so we're able to reach out to them and put together mini working groups. And we need content for 40 minutes on this topic. We need 50 minutes of content on this topic. And you're talking about world leaders putting this together. And so what our vision is with the EIM credential is that it starts from the assumption that you are an exercise professional, that you have that knowledge. We're not teaching you how to do that. You need to have that coming in. And it doesn't have to be an ACSM certification. It could be NSCA, it could be ACE, it could be different organizations that there's this ranking criteria. And we're taking the top 12 from this list. And, the ones that I really trust, but what we're doing with the credential is now we're adding on. So it's like a form of enhanced continuing education on top of your base exercise professional training. And really the components is making sure you have a really deep understanding of how to work with patients with various health conditions. So you have an older adult. Do you understand all the issues that go along with frailty, with sarcopenia? What do you do, and how do you really work with this patient population? And we're doing that with chronic diseases and cancer and women who are pregnant and so on and so forth. So that's a key part, because to get an exercise certification, or you don't necessarily need that for a lot of them, and it's kind of surface level. So we want to make sure that there's a really deep dive into how the healthcare system works, healthcare law, healthcare systems. So that way, when you're trying to communicate with that healthcare team, you understand the language that they're using. And this is something that I don't think we teach in our typical exercise science courses, right? We tend to we're trying to bridge that gap of understanding that. The other thing we want to do is make sure people have a great understanding about group-based exercise, because it's probably not feasible that we're going to be able to execute this in all one-on-one environments. That's very costly, it's expensive. But if we can run programs at the YMCA where 10 or 12 people are coming in at a time, now the cost comes down, it becomes more affordable for the patients, and it just works for everyone. So it's really teaching that exercise professional how to really integrate as an extended part of the healthcare team.
Yeah, and if I'm out there right now and I am someone who's really interested in this, the program currently exists right now, and there are a number of EIM certified professionals out there. If I'm one of those people and I'm struggling to be able to attract that client population or that patient population, do you have any advice for that person as to maybe how they could start engaging the healthcare community in their local area?
Yeah, and I think this training will offer some suggestions and more insight as you understand how the healthcare sector and the healthcare world works. Because there's gatekeepers, and you walk into a clinic, there's a gatekeeper, and you can't get past them and through them. And you have to, and so in some regards, as we're talking here, it's for exercise professionals to be successful in this realm. So we're not in a gym and people are coming to the gym. We're trying to get people who aren't in a gym and convincing them that exercise is good for them and to be part of our programs. It's we have to become more multidimensional and learn skills. How does a pharmaceutical rep get past the gatekeeper? What do they need to do? Obviously there's things that we don't have the finances and different things, but what can we learn from them about being able to get 15, 20 minutes with a physician? What are the tools and marketing materials, and how do we build that trust, and what does it take? And honestly, I don't even know that information right now. And it's something that's always been, I think this is a really great research topic, is trying to find out how this is done and how we can do this in our world. But what I do see success though, and before being at Temple, I was in Tennessee, Chattanooga, Tennessee, and I actually worked with a group that was their motto, was developing relationships with health systems, healthcare providers. And it was just a scramble, and they were constantly meeting. They're hosting, webinars and presentations and continuing education. So, hey, can we come into your office and give a lunch session for 20, 30 minutes on just physical activity in general? And they were able to build up that trust. But it wasn't something that happened overnight. It took a lot of work. Sometimes it was working like, well, my family physician actually connected me to someone else who connected me to someone else. And it's just physician by physician. But if you think of it, each physician, each nurse, they're seeing 20, 30, 40 patients a day, multiply that by how many days a year. Even just getting one person on your side, it's a huge effect. And then you get the second one and the third one, and you have to produce high quality work, because that work, the message always gets back to them. And they hear positive things, they refer more patients. If they hear one negative thing, that's it, it's over. So it's a lot of work, but I think there's a future to it. And I hear stories from around the country of people who are really motivated and get out there and get on the hustle and put in the time to develop these relationships. And I think it can be a viable option for people around the country.
Yeah, and I think the fitness industry as a whole is very much maturing. We're still a very young industry by rate of comparison. Maybe the mid to early 70s is when you'd start to consider the fitness industry actually being a formal industry. And I feel like we've evolved from bodybuilding to weight loss to health, and now more to wellness even. So maybe this is just part of that maturation process as an industry.
Yeah, and I know I'm not involved in these talks, but EIM and leaders at ACSM are really looking at that. The fitness industry is hurting right now. We just went through this pandemic, gyms were closed, people are a little hesitant, so they're looking to see what they can do to kind of get people back in feeling safe. And the opportunity is there. So not only do we have to work with the health side of things, we have to work with the fitness industry to make sure that we have people trained, to make sure that we have gyms that have doors open. The other day, I was speaking to a director of a medical fitness facility in New Jersey, and what they've worked out there is that as patients get referred from their partner health system, that they were going to give them 6 weeks free of a class 2 times a week for 6 weeks. And what they figured is, yes, we lose money by doing that, but we get people into the gym that wouldn't normally be here. And that might drive our membership. And maybe it does, and maybe it doesn't, but I like the ingenuity of it, because it at least gets that person 12 sessions of guided exercise supervision in a trusted facility with highly trained people. Now, whether they continue on and can afford a membership and other things, but they may or may not, but I would imagine that drives some membership and it's a benefit to the gym. and other people might continue on being active on their own. So I think those are the unique types of partnerships we need to take a chance on and see more of.
Yeah, I think in the creation of any new movement, I think it does take a lot of creativity and a lot of ingenuity to really allow it to blossom. Now, you said something earlier that I want to go back to, and it's about those champions. And I think as we come to a close here, I want to maybe give some action items to people that are listening to this that this resonates with and that they're inspired by. So if I'm a physician or a nurse or I'm a healthcare provider out there and I'm like, wow, this exercise is medicine. I've always believed that for myself. I just didn't actually realize that this exists formally in any type of a structure. What's the first step if somebody's interested in it from the healthcare sector? What should they be looking at? What information should they be trying to read to actually start to engage with this?
Well, we've done my boss and leader of EIM, Robin Stewart, who leads the whole EIM initiative, has done a great job of putting a ton of resources on our website. We have, we have handbooks, we have guidebooks. So, I think that's a first stop, for both health systems and exercise professionals. Exercisesmedicine.org. There's tons of resources there. And I think that's a good start to just read. And we've made it simple. They're not heavy, dense handbooks, pictures, illustrations, tools to use. Gets people started. But they can always contact us, and by doing so, a lot of times we try and connect them with people in the field that are doing stuff, try and provide guidance. I think we're always willing to get on calls with people and help them along in doing that, because at the end it is tough and there's a lot to do, and a lot of hurdles and a lot of barriers, but there's a lot of people who've done it and been successful. So, Liz Joy is our leader at Intermountain Health, one of the most giving people out there. Her passion is life just to see this be successful. And she, if there's a dedicated person out there that's willing to put in the time and effort, she's willing to get on the phone and help them. And so we have a wonderful network of people, not just staff, Robin and myself and our other team member, Shelby, but we have a connection of people. And as we grow it, through the Research Learning Collaborative on the research side, starting to connect people with great researchers, Sarah Linke in San Diego, Michael Pratt's there, Felipe Labello is in Atlanta. So we're starting to develop these networks of, okay, I'm really more about the implementation of the actual program. Okay, we could connect you with these people. I'm more interested in research. Okay, we can connect you. I'm more interested in the community side of things. Okay, here's some people that are doing it. And we need to grow it. We're not where we want to be. We have a long way to go, but we do have a lot of resources on the web and a lot of people are willing to help. So, check out our website, get in touch with us, and we'll find a way to help you.
Yeah, and I will make sure I link up to the website as well as all kinds of other information about EIM in the show notes, so it's really easy for people to find that information. But yeah, we're literally building a community. We're building a research community, a medical community, a practitioner community, and community building takes time. Well, Mark, thank you so much. I know this has been a really enlightening conversation for me, just hearing about all the different things that are going on. But I think more importantly, for everybody that's listening, just getting an idea that this initiative is out there, it's gaining momentum, but the way that it's really going to propagate on a larger basis is to get more people involved. So as I said, I'll link up to all the information on EIM in the show notes. Mark and his team at EIM seem very, very willing to collaborate and help anyone that's interested in this. And I hope everyone's found this conversation as enjoyable and insightful as I have.
Yeah, it was a pleasure being on. Thank you so much for having me today, Michael.
Well, I truly hope you enjoyed that conversation with Mark as much as I did. If you found it insightful and valuable, please share with your friends and colleagues. Those shares really can make a difference. In listening to Mark and having the conversation through the episode, I think the one thing I was struck by is that we have an uphill battle here with exercise as medicine, but it's a battle that we must fight, and we must fight vigorously. We know healthcare costs are only escalating, and healthcare costs are escalating because the treatments, the pharmaceutical interventions, the surgical interventions, the clinical interventions are all just exponentially more costly than lifestyle interventions of exercise, physical activity, nutrition, sleep hygiene, and so on. This is not only a battle that is worth fighting, I feel this is a battle for the very soul of the health of our nation. At this point, diabetes rates are on the rise, cardiovascular disease is on the rise, and there's no signs of any of these slowing down. For the first time in the history of our country, we have a national obesity rate of over 40%, and the trajectory of that obesity rate is only going up. If there is a fight that we choose to pick as wellness and fitness professionals, this is the fight. And it starts with us uniting. It starts with us coming together. It starts with all of you going to the Exercises Medicine website, which will be linked up in the show notes to find out more information. And it's about supporting this initiative and telling it from the mountaintops to as many people as you possibly can that this is just not a catchphrase to sell gym memberships in our industry. This is a viable and valid public health intervention that, if implemented properly, can change the course of not only the healthcare system in our country, but can also change the course of our economy, because those two things are so intrinsically tied. Well, I truly hope you enjoyed this episode. Please don't forget to subscribe through your favorite podcast platform. And don't forget to be on the lookout for next week's episode when it drops on Wednesday. Until we chat again, please be well.